All right, we'll go ahead and get started with this next presentation. If you guys want to find your seats. Elizabeth Burkland is a registered dietitian at the Diabetes and Nutrition Education Center at the Mary Greeley Medical Center in Ames. In her role, she leads group classes for diabetes prevention program, type 2 diabetes, gestational diabetes, and cardiac rehabilitation. She is also involved in the Mary Greeley Medical Center's Mileage Club, a program with the elementary and middle schools in Story County which promotes running and walking and living healthy lifestyle for school-age children. And she is a member of the Healthy Food Choices Committee with Healthiest Ames. Please welcome Elizabeth Burkland. I do want to say she's very humble, but she just had a baby 6 weeks ago. And we are very lucky that she's able to present. I'm very fortunate that she was here as well, so thank you.
Yes, this is my first outing without him attached to my body, so I feel very free, but also excited to get to see him when I get back home. So, yes, I'm Liz, and we'll be talking about maintaining our diabetes prevention program and getting started with the Medicare program. This is all our experience at Mary Greeley, so it's going to look different for you guys, and depending on where you're running programs, but this is how we've gone about doing things. And kind of briefly, we're going to go through our timeline at Mary Greeley with the program, our keys to our success with the program, getting started with Medicare, and then our next steps, kind of moving forward, how we want to continue advancing. So our timeline just kind of briefly looks like this. We started a pilot group in October of 2016. This was a group of 9 people, employees at the hospital, who agreed to kind of be our guinea pigs, getting started, helping kind of break me in as a coach, getting used to these long-term sessions. This is also my first job out of college, so it kind of broke me in just getting to know how to talk to patients in general. We did start our data tracking with that first pilot group as well. So our submissions are going at September and March, now that we're submitting data every 6 months. A huge benefit that we have at Mary Greeley is that our hospital actually adapted the program into our insurance plan for our hospital employees who have our insurance policy. So that started in January 2017, a few months after we got started with the pilot group in October. We were able to start 2 groups in January when that happened, which we'll get into in a little bit. So our first submission was September 2017, and we were able to gain preliminary status. Our data was looking good at that point, but we didn't have a full year submitted yet. And then in March of 2018, we had a full year of data. We were able to submit to the CDC, gain full recognition. We were meeting all of their guidelines, the 5% weight loss. I think we were at 7.9% for our first year, so kind of our pilot group did really well, and was able to get that full recognition for us. About a week after I sent our slides into Andrew, we got our second year of data, our 24 months, and we're still at full recognition. So still maintaining at least that 5%. We're a little, I think we were at 5.9% with 2 years in. The MDPP group then, of course, CMS started accepting people in April to start doing the program. We got our application in right away, and we're able to start our first group in May because we were meeting CMS's guidelines for Medicare. So here are some statistics. The screenshots are maybe a little bit off because I've been out of work for 6 months, so I haven't been able to keep updating our data with DAPS, which I'll talk about DAPS a little bit more later on. But here's what I was able to pull up from the website right now. So we've had 10 cohorts go through. We're starting groups about every 3 or 4 months. That works really well for us, and I always aim for anywhere between 8 and 12 participants. Our classroom that we're in really can't hold more than 12 people, which I kind of like, because any more than 12 I feel like would be kind of hard to juggle the conversation, reeling people in. I love to have 10 people in a group. Less than 8 people, I feel like if you have 1 or 2 drop out, which happens nearly with almost every group, then you're down to 6, and then if somebody's sick and somebody else has to stay at work, you're down to 4 or 3 people, and that's just also a hard conversation to stick to. So we really like 8 to 12 in our groups. 9 of those cohorts have been just the regular DPP program, and then 1 of them is our Medicare group that we got started. Our activity minutes are 242 minutes on average per week that people are getting, which is amazing. The goal is 150, so I feel like because I've heard so much about activity being the best thing you can do for your health, that our participants are going above and beyond that is really exciting for us. And then our weight loss on average, I think it's a little bit higher than this 10 pounds, but it's somewhere between 10 and 12 pounds per participant. One thing I do that I think helps us gain those higher levels of activity minutes is I put out baskets at each session. I have a basket they can turn in activity minutes and a basket where they can pick up the ones that I've collected and entered in for our data. So that way everybody is always turning that in, and I don't have to badger everybody to get those in. They kind of take it upon themselves to badger each other to get their activity minutes in, because the groups, you know, if somebody's turning it in, hey, I'll take your minutes up for you, put them in the basket. That works really well for us to make sure that I'm always getting those activity minutes counted. If somebody forgets, I send them an email right after class. I'm like, hey, can you send me your activity minutes for the week? And they might screenshot me their activity log or send me just kind of their tally for the week on activity minutes. So I rarely miss those being turned in. Our blood-based test, so the CDC does require 50% of your participants have to have that lab value, and I know listening in on some of the calls that that's difficult for some people to get that 50% of participants with the A1C above 5.7 or the fasting glucose above 100. I think one benefit that we have being a hospital is I have to chart everybody in our electronic medical record, which gives me the opportunity to see that they've had, you know, most of our hospital employees are having physicals annually, and I can go and see, yeah, that person had a glucose that was above with their fasting values, and I enter all of those things in, so that helps us a lot. I always pull people in with the risk test. I give everybody who's interested in the program that risk assessment. If they score 5 or higher, then I say, oh good, you've qualified for the program. And then once they're in our charting system, I go in and double check those labs. Like I always have just guessed about 80% of our participants had those lab values if they scored 5 or higher. And that is apparently correct. 79% do. So these are some of the things we're going to get into. I'm not going to cover this a lot, but gaining participants, we'll get into how we did that, what we've done within the meat of our program, and then how to be resourceful to utilize those other departments and resources out there to have a success with diabetes prevention program. Okay, so gaining participants. If you can find a covered patient base to kind of target as your primary people to bring in as participants, that's very helpful. We had Mary Greeley in January 2017, and then McFarland is our clinic, and they have a lot of employees as well. They signed on and included this in their insurance program or policy in January 2018, so we have quite a few people that I can kind of target and ask to participate. But if it's not your employer, if you can find maybe a large business in your town or near you that would be able to incorporate this into their insurance plan, makes it a lot easier that you don't have to worry about the funding per participant. So within those populations, we advertise a lot with the weekly newsletters. So the hospital sends out a weekly newsletter, and so does McFarland Clinic. And anytime I'm getting ready to start a new cohort about a month or two in advance, I ask to start putting that in the newsletter every single week. Kind of a blurb about what the program is and when our session 0 is going to be started. Session 0, if you're not doing that right now, it's very helpful to kind of pull people in to just hear about the program without fully committing to the full year yet. Helps me get to know who's interested and kind of like who might really participate the whole year and who may be on the fence and needs a little bit more time. Maybe they want to participate in the next group that's coming up in 4 months. And it also helps them to get to know me a little bit. Like I said, this is my first job, so I'm kind of a new face around the hospital. Helps them to get to know me and hopefully kind of open the door there. Within the community, we've done a lot of kind of advertising too. We did have kind of one big meeting with 5 of the main, 4 or 5 of the main big businesses in Ames, asking them to incorporate the program into their insurance policy. 3 of those businesses, including the hospital in McFarland, have started putting it into their insurance plan. So that was great. It's kind of a good opportunity if you can bring in multiple people to listen at once, and then it's like, oh, if our primary care clinic thinks that this is important to give to their employees, maybe our employees would benefit from this too. You get kind of that roundtable discussion. A lot of honest questions are asked at that meeting that we were able to answer and just be face to face with some of those HR people and people who are making those decisions for the insurance. I've also done some of smaller businesses have heard about the program somewhere, so I've just gone to them and did a lunch and learn with some of their employees and some of their people in management to kind of open up their ear about the program. None of that has come to incorporating it. I don't know that they have to say so with smaller businesses to put it into their insurance, but at least if Blue Cross Blue Shield does incorporate it later on down the road, they've heard about us, they know that we're offering the program, and hopefully they'll start promoting it once, you know, if there is more coverage, which I'm really hoping that there will be for all of Iowa. And then community presentations. I've presented probably a dozen times on our program. I've gone to the Rotary, I've gone to the Lions Club, the Noon Lions Club, Iowa State's Foundation, lots of different places around that just have different people who are hearing about the program for the first time. Some of those are good volunteer places where they're retired, so then Medicare coverage is huge in those community places. And then we also were able to present to the, who's in my train of thought? Primetime Alive, which is a place where people who are retired, they come like once a month and listen to a wellness talk at the hospital. So we got in on that, and we were able to say, hey, Medicare is covering this in May. It's looking really good that we're going to be able to, or in April, it's looking really good that we'll be able to do that program. And we got a lot of people interested in that. So if you have a Silver Sneakers or something like that that you can go to speak, that's a great resource. Tell your patients, this is maybe seems obvious, but I'm a dietitian, so I get a lot of our pre-diabetes patients who are referred just for nutritional counseling, and even some people who are just referred for weight loss in general coming in. And if they seem somewhat interested, or if I see that their lab value is elevated, I tell them about the program. Even if I don't see a lab value elevated, but I can tell that this person just wants more than a one-on-one session that's just an hour long one time with me, I'll say, hey, what do you think about filling out this risk assessment? And you know, if you score 5 or higher, you can be in this program, and they're really excited about it usually. So I tell a lot of my patients about the program, and tell them when the next cohort's getting started. And then I call them up once it's getting started. I'm like, hey, remember me from 2 months ago? Would you like to get in this now? And usually they'll come in for that session 0 and decide at that point. I try to leave it very open-ended, very up to them on if they want to come back to do the program, especially if they don't have those lab values but scored 5 or more. But that risk test does open a lot of eyes on, oh wow, I've never thought about diabetes, but if I'm scoring 5 or higher, maybe I do need to start considering this. So kind of gets them thinking that direction as well. The other thing with telling your patients is you can offer that support. So a lot of these patients who are referred for nutrition counseling, they've done some fad diets on their own, or they've done the thing with their best friend trying to lose weight, and they're wanting that professional opinion. They're wanting research behind the next thing that they try. So that's one thing with the diabetes prevention program. You can show them, 58% of people were able to reduce their risk of developing diabetes. We're looking at a moderate amount of weight loss and increasing activity. The other good selling point for patients that I see is that social aspect, that they're not just doing it with their husband or their friend, where if that person falls off the bandwagon, they're probably going to fall off too. They've got 9 other people there supporting them and pushing them to keep with the program, and that's a big selling point for a lot of our patients that I see one-on-one. They want that social aspect of the program. Utilize DPP websites. The CDC Diabetes Prevention Program website has a lot of great marketing material. That's where I started with a lot of our flyers came from that website. I get a lot of the data. I go back to that website a lot just to see if they've updated anything or if I missed something from the last time I went through. So definitely use that. And then if you haven't heard of the American Medical Association's website, it's the STAT website. If you're going out to physicians to speak to them, they've got a lot of data and a lot of talking points that are geared towards having that conversation with a physician. So if you Google AMA, STAT, DPP, it'll come up, and that's a really good resource for talking to any physicians. CMS, of course, has all the information for Medicare, and then IDPH has some good statistics for Iowa diabetes and pre-diabetes, so good resources there when you're talking to people. Okay, within the program, one of the other things I really like that we've done is we're picky with our coaches. We use just registered dietitians and nurses, and then some of those people are also CDEs. So we have a really strong foundation with diabetes, which helps answer those complicated questions that always come up with our cohorts. I think it's great that we've got kind of more of that professional opinion. I know you can use lay people, and if we did that, I would still want to oversee everything that's going on. But it just would make me nervous with some of the, because I'm a dietitian, nutrition questions. If somebody was doing a fad diet and it was working for them and they promoted it to the group, I'd be like, no, that's not what we're working towards. We want a sustainable, healthy way to go about moderate weight loss and maintaining that after the program ends. So we're picky with coaches. We now have 4 coaches, which is really great and nice to rely on those people when you have a baby and you need to be gone for 6 weeks or 12 weeks. And it's great to bounce ideas off of having multiple coaches. For a long time, it was mostly me running all of these groups. And I think I try new things with each group, but being able to sit in with our new coaches and listen to how they present this information and see, what ideas they have for that extra little thing that you add to the material, it's really great to have more ideas kind of flowing and have somebody to bounce ideas off of. So if you can have multiple coaches, that's great. Utilize the program material and then some. One of the best pieces of advice we got after our first data submission was to incorporate extra sessions. Our pilot group, we did the 16 weekly sessions and then a couple of every other week sessions, and then at 6 months we went straight to the monthly sessions. That's a hard transition for people when you're meeting weekly to bounce to monthly. That you lose people when you start stretching it out that much. So we now do 29 sessions. We do the 16 weekly. We go to every other week for the next 4 months of the program, and then we do monthly at the last 4 months because I still want to give people that opportunity to try to figure it out on their own without relying so much on that group support. We still sometimes have people dwindle a little bit when we go to the monthly at 4 months, but we've got enough data with the every other week sessions that have been stretched out long enough that it still helps support our data that we're submitting to the CDC if we still lose a couple. And we don't lose as many as we did when we were doing straight to the 6 months. We're starting every 3 to 4 months, which if you have enough patients that you can do this, it really helps with our data submission to keep our numbers high and to keep those different levels of motivation, I think both for me as the coach and for the participants, so that each time we're submitting every 6 months, we've got different levels. If you've submitted data, I think that makes more sense. If you haven't, I apologize if that doesn't make sense. But it helps to keep our numbers up quite a bit to start groups every 3 or 4 months. So we do utilize the CDC's material. I think they offer 26 sessions online. We're doing 29. One of those sessions I don't count towards our data. We go to Hy-Vee for an evening and we do the Simple Fix program, and that's kind of more, I see it as kind of a team building experience where that program, they are making freezer meals that they get to take home, and it's like 8 meals. It serves 4 people and they love it. It takes about an hour long, so it's the time of a session, but I don't bring the scale to Hy-Vee. I'm not going to weigh people at the grocery store, and I don't ask them to bring their activity minutes. Some people still want me to see their activity minutes, and I look at it and it's fine. But that I don't count towards the CDC. It's just kind of a bonus. The other 2 extra sessions beyond the 26 is we'll kind of briefly review something that's already been covered, and then I add on something else. So as a dietitian, I love mindful eating. So we review one of the first, I think it's like the 3rd session where we talk about the My Plate and the different food groups and why we want high fiber in our diet and that sort of thing. And then I bring in clementine oranges and we do the whole mindful eating experience of like slowly peeling the orange and smelling it and thinking about where it came from and eating it as slowly as possible. So we incorporate that into one of the sessions as an extra. And then the other session that we do is we'll review one of the activity sessions. You can pick whichever one fits your group the best. And then one of my coworkers actually just got her certification as a yoga instructor. So she'll do like a 45-minute yoga session with our group, which you could do stress management there because there's a lot of meditation with it, or you could do it as an activity session because it's just a very basic foundational, here's how you stand in this yoga pose without hurting yourself sort of thing. So that's our kind of bonus sessions that I get to incorporate. We do have some events like the Hy-Vee Simple Fix. I consider kind of an event. We've done, I've done like walking groups at noon. Anybody who's in any of the programs or groups can come to a walking group at noon with us, maybe once a month. We've done the Healthiest Ames or Healthiest State Initiative. Some of our groups have signed up to do that kind of outside of class to kind of stay in touch with each other. So anything extra that you can add that kind of brings more interest and gets people excited outside of the general sessions is really beneficial. Listen to your participants, starting with session 0. So that's another thing I like about session 0. I bring them in, I tell them about the program, we do a PowerPoint, and then I let them know that we're covering more than what the CDC requires. So if they want anything else out of the program that's not necessarily there, tell me and we'll modify it to whatever the group wants to do. I'm okay with that. For example, I had one group say they just were really struggling with meal planning. They wanted more. They didn't understand how to put the meal together, even though we went over the My Plate. So we did a session on meal planning where I printed out worksheets and gave them all kinds of resources, and everybody could make their own meal plan, based on their family of 4 or their couple of just 2, however they wanted to do that. So listen to your participants and try to really follow up on what they're telling you. Do that at the midpoint session. So that 6-month session is a good opportunity to ask those questions. You get to kind of review what you've already done, and then you get to set new goals for the next half of the year. And this is where we're not meeting as often. So I tell them, look, I want to make the most out of the last 6 months that we have together. What do you not like about what we've done so far, and what do you wish that we could start doing more of, so we can fill in what the group really wants? Because not every group is different. Every session is a different conversation. And I love that about the program. It makes it a little bit challenging, but also makes it more exciting as the coach. So really be open to changing things up. And then be flexible with what you're doing. One of the big feedback things is the action plans. A lot of my people did not get the action plan, and I would go over it like every other week. Here's how to fill out your action plan, and write out sample action plans, and still the next week they're like, I didn't do it because I don't know what we're supposed to be doing with this. So some people got it, but a lot of people didn't. My supervisor read a study on these groups who were trying out if-then plans. And it was with the diabetes prevention program, and they found that the people who were doing if-then plans instead of action plans were actually a little more successful with setting the goals, and then more successful with their weight loss and activity. So that, I developed my own worksheet based on that study she handed me. And it's basically they set one goal instead of the 3 that the action plans kind of have laid out. They set one goal, they tell me how that is gonna look in their life. So my example is always water. I wanna drink more water. Well then what's that look like for you? I wanna drink 64 ounces of water a day. Then they tell me 3 challenges that are gonna come up with drinking 64 ounces of water a day. And then they put those 3 challenges into an if-then plan. If I forget to drink water, then I'm going to have a bottle sitting in front of me on my desk every day. If I get tired of water, then I'm going to bring in hot tea that I can still count towards my water intake. So they put those challenges into an if-then plan. And then at the end, they have to put in what they need to do in order to accomplish that. So they need to pack a water bottle from home. They need to buy the hot tea from the grocery store. Those things. So they're really breaking down that goal into a almost fail-proof plan for the week. I still have some people who don't quite get that, but I feel like we've made a lot of progress from our general action plans, and a lot of people really liked when we switched to those if-then plans. Yeah.
Do you look at everyone's action plan, or do you just talk about them at the table?
I don't look. She asked if I look at everybody's action plans. I don't. Mm-hmm. I do at the beginning of each session, especially in the beginning, and I probably should do a better job further into the program. We'll take 10 minutes or so at the end of each time to write those plans out. And then sometimes I'll have every single person read off their plan. So then the whole group hears about it. And then they get ideas from other people like, oh, you should do this, to help you out. Okay. And then the next session, we'll spend 5-10 minutes asking each person how they did. Mm-hmm. So they definitely are more excited about it at the beginning of the program, and I try to keep it going through the rest of, the last 6 months, but that's how we do it. Also, with being flexible, be, I think, open to some of those ideas. The CDC, in their handouts, offer a lot of suggestions. One of those is like meditation, meditate with your group. That made me very uncomfortable when I first got started to meditate with people. But I did it, and it still felt uncomfortable. So then I signed up for a 6-week meditation course outside of work, so that I felt like I knew what I was doing with it, and I felt like I could convey that strong message of, here are the benefits that you can get out of it once you're actually doing it. So be open to doing some of those things if you have that, even if it's an online course or just getting on YouTube and practicing some different meditation. Another thing that we've done is like coping with harmful thoughts. That's kind of a tricky session to do. It can go down a negative road pretty quickly. To bring that back up, I print off a ton of inspirational quotes and I tape them all along the walls. There's like 30 quotes up, and then at the end of that session, which has maybe been kind of a negative session in some ways, they get to get up, go find a quote, and then we stand around the table and each person reads the quote that they picked and why they decided that that one spoke to them, just to kind of flip it around and leave everybody with a good, feel-good feeling, rather than like, oh, yeah, I'm still coping with those negative thoughts. Because they come up and we try to normalize that yes, it's okay if you kind of slip back every now and then, but we gotta keep switching them to kind of more positive aspects. And then makeup sessions. I know that this is a tricky piece for a lot of people to find time to do makeup sessions. But if you can find the time and make the time, especially in the beginning of the group's program, then it really pays off in the end. If I hassle people to get in to spend a half hour with me to do those makeup sessions one-on-one outside of class, they are better at not missing class because then they have to find the time in their own time that's not blocked out to come see me. I also like the makeup sessions in a way, especially for people who are maybe struggling with the program, because I don't have the personality to call somebody out if they're struggling with the weight loss or if they're struggling with getting their activity minutes in a group setting. I can't do it. So when I can have people come in one-on-one, it gives me a better opportunity to figure out what's going on with that person. Hey, I noticed that weight loss has been a little bit slow. Is there something that I'm missing that you need from me to help you out, or that you need from the group? Do you need a buddy system, or are you not quite understanding something with the food? And people are always pretty quick to open up and tell me what's not working for them, or if something really stressful happened in their life that's just come up that they don't want to tell the group, but they're more comfortable telling me one-on-one. It just helps to get a better understanding, I think, from their side and my side. So stay on top of those makeup sessions, especially in the beginning. If I have somebody who's struggling in the program and they're never missing a group, and I don't know how to bring them in on their own, then usually at the 6-month mark or at 4 months, I'll offer a one-on-one session with everybody in the group and try to really get to those people who are struggling a little bit more. So that way it doesn't feel like I'm aiming at them specifically, but I can still bring them in to talk. So be resourceful, rely on the other people who are working around you. This helped us quite a bit to diversify advertisement. So we have this Health Connect magazine that goes out, I think, to all the people in Ames, or at least most of the people in Story County seem to be reading this magazine. Our communications department came in, they interviewed myself and my supervisor as the coaches, and then they interviewed 3 people who were in our pilot program on just what the program was, how they felt about their experience within it. And then this magazine went out to our community, and we got a lot of phone calls of people saying, hey, what's this program? How do I get to participate in this? And then that helped me kind of find those people who were not our patients, pull them in. So if you have something like that, or a newspaper, or some way to reach out to people outside of kind of your scope, that's really helpful. We also just have information on our website. We use Facebook to tell people when we're starting a new group, and then word of mouth and emails are great for the ones that you do know or are closer to you. Billing and charting, we had to have a lot of help from those departments to come in and kind of build those codes for us, to lay out what do I need to put in Epic when I'm seeing a group. Do I need to chart on each person individually? Yes, I do. Some of those questions were answered in sitting down with those departments. And then technology I have just in case you need a new app on your iPad. I use a lot of apps. I think with my groups, we have an app for meditation, we have an app for tracking food, an app for tracking activity. I use a lot of them. So our iPad, they have to put those things on, or if I need speakers put in our room or whatever, get close with your IT department, they're helpful. Guest speakers, we are fortunate to be in the same area as cardiac rehab, which there is a huge tie between heart health and diabetes, obviously. And the session that is on heart health for the program, I bring in one of our cardiac rehab nurses to explain that. And they do such a better job at explaining why we shouldn't be smoking, although I don't think I've had any smokers. Why we shouldn't be smoking, they explain, the relationship between plaque in the arteries, and they bring in a big model and really explain it to people, and then they get to ask those questions about blood pressure and cholesterol that I don't know how to answer directly to the source. So that's really helpful. I've had a physical trainer come in and just do basic exercises with our groups. And the benefit there, I think, was form, on squats and how not to injure yourself, or how to work around a knee injury, that kind of thing. And then relying on coworkers. Like I said, my coworker who's a yoga instructor now is doing a yoga session with every one of my groups. So whatever in you have with somebody, utilize them to come in. I think it's exciting for the group to have a new face every now and then too, so I'm not the one that they're always seeing. I'm there, but they have somebody else too. And then data tracking with DAPS. This is AADE's version of their online tracking system. Chronicle now, if you prefer to use the ADA, they have an online tracking system, and this is so helpful when you are getting ready to submit your data. It is one more place where I have to enter my data because I keep track of it in my own Excel file, and then I put it into Epic, our charting system, and then I also have to put it into DAPS. But when I have to submit my data, I just know that it's all there and it's all right, and I don't really have to worry about it. I just can export that file, they convert it for me, and then I just put it into the CDC's website. So it's really quick, really easy that way.
Liz?
Yes.
You mentioned charting and billing. We're not to the point that we're billing on any of our clients yet, but are you charting simply for the Medicare patients or for all of your patients that are being billed?
I'm charting everybody. Anybody that because we're billing everybody probably, but anybody that I see, my regular DPP groups, it's just a very quick note, the topic we covered, their weight, their activity minutes, and that's pretty much it. If I feel like I need to add something, I will, but really quick. Medicare, I had to build a full note.
You did,
okay. And I'll cover a little bit more on that here coming up. So I'm charting on everyone.
Thank you.
Okay, so Medicare. We have one Medicare group going. We started in May. Just kind of a quick, what's Medicare's program versus the regular program, because there are a few differences. Medicare's is 2 years, so the first year is the same as the regular program. The second year is monthly follow-up sessions for anyone who has met the weight loss of 5% and attended so many sessions throughout the year. They get to participate in a second year of follow-up. It's covered 100% by anybody with Medicare Part B. Medicare Advantage, don't ask me questions on that because I don't fully understand it, but I think there's some coverage with Medicare Advantage, possibly all of them, I don't know. The billing, the G codes there's like, I think 20 G codes, maybe more or something. There's a lot of different codes that you have to keep track of, each individual on where they are with the program, where they are with weight loss, where they are with how many sessions they've attended. So you have to stay on top of those G codes, and then the charting's a bit more complicated. This is a picture, just a screenshot of the roadmap. That is on the CMS website, and I have a link to that at the end. So some of those tools are helpful in kind of understanding and explaining the program to the billing department and the charting department or your electronic medical record. Because they don't really understand sometimes the inpatient side of things when you're trying to get this going. So read the Federal Register final rule and then reread it and then have a coworker read it and then ask your coworker questions about it and listen to all of the webinars that are offered so that you understand what you're doing with the getting Medicare set up. I've read it several times and then I have it highlighted and I have it earmarked and in a folder in my desk. So that helps in building the notes, the chart notes, making sure you have all those elements included. And then it also helps with making sure that you're billing correctly when you are getting those G codes in, putting those in correctly. So definitely go over that, as annoying as it is to read all of that jargon. Do that. That's the link to those fact sheets. And then here's another one that we've used quite a bit, the expanded model fact sheet. It just kind of helps to briefly explain the program. These eligibility requirements are on there. So the BMI is something with Medicare. Your participants do have to have a BMI over 25 or over 23 if they identify as Asian American. You wouldn't think that would be an issue, but with Medicare, some of these people have the elevated lab value and their weight isn't high enough, so you have to kind of explain to them that it's probably genetics that is going on, and unfortunately Medicare is not going to cover the program if their BMI is less than 25. So one extra thing I had to kind of pay attention to, the blood test is a little bit different as well, so they have to have a fasting glucose of 110 to 125 rather than 100. To 125, so you have to pay a little more attention to that. I have found that if people if they were in that 100 to 110 range, if I could somehow get their doctor to order an A1C, I capture a lot more people with the A1C of 5.7 to 6.4. So if you can work that in, I think it's because generally with prediabetes, you start elevations in your postprandial numbers before you start seeing elevations in those fasting lab values, and the fasting one's what everybody gets done at their physical. So the A1C catches a few more people if you can do that, and it's the same for both the regular program and the Medicare program. And then they can't have a previous diagnosis of diabetes or end-stage renal disease to participate. So a couple extra questions you have to ask those Medicare participants that you don't necessarily have to think about with the regular groups. So we did have another big meeting with CAS, which is the people who do our charting stuff, the head of the billing department, Cody. They were great at letting me kind of put how I wanted those G codes worded so I knew what they meant, and then they built just little buttons that I just click to submit those charges, which has been very helpful for keeping me on track. Our charting system, they let me just write up a note that I wanted it, how I wanted it to look like in a Word doc, and I sent it to them, and then they built that note, so it makes charting a little bit faster, although charting does take longer with the Medicare groups. Not a ton longer, but it does take a little bit longer with them because you have to make sure that you get all of Medicare's requirements in each note there. So, and I went to the Federal Register to figure out what I needed and what those details look like for the chart note there. So, gaining participants. Luckily, because we're starting groups every 3 or 4 months, I had several people who were maybe like 64 or they were 66, wanted to participate in the regular session, and I told them, it really looks like Medicare is going to cover this in April. Like, no promises, but this is what it looks like. Actually, I started with January, and then we moved it to April when it changed. So I had a lot of people kind of on the back burner, just kind of crossing our fingers that they didn't somehow get diagnosed with diabetes in the interim, so leave that decision up to them, but now you don't have to worry about it. So I had a lot of people I was able to just call up and say, hey, good news, the program's covered, come in for another session 0, please, because I have new things I need to ask you, and they were all really great to come back in. I also got a lot of people from that Prime Time Alive presentation, which is kind of a lot of our retired people who come to that. We've got a pretty good sized group in Ames, people who participate in Prime Time Alive, so got in a lot of doors there. And then, of course, again, any patients that I had referred to me for prediabetes, I was able to ask if they wanted to participate in the program. And the selling point that it's covered 100% is great for this population. Don't need to do much selling, actually, once you say there's a program that's covered. This little screenshot is from the CDC's website, so that's one of the marketing tools that you can use. I'm sorry that I'm talking too much. I'll speed up. Our first cohort, 9 participants, 2 men, 7 women. That's pretty normal for all of my groups. On our first 12 weeks, data, average weight loss is 5 pounds, average activities, 243 minutes. That was something I was worried about with the Medicare group. I didn't know if they'd have more injury or just be a little more hesitant to start getting active. They are amazing with activity. Like, almost all of them are getting over 150 minutes consistently every week. And then 4 of our participants at 12 weeks had already met the 5% weight goal. And I have 12 weeks because that's the last time I looked before I was off work, but I know I think I had 2 more people meet the 5% goal before I left, and 1 person met the 9% goal already. So if I can say anything about Medicare, if you're nervous about if this is gonna pay off because you get reimbursed at such an odd rate with Medicare, they are amazing. They're so motivated. They are so connected with each other. The conversation's a lot different with them. I can't use all of my apps with my Medicare group. We have to go to the library to check out DVDs and that kind of stuff, which is fine. I'm learning a lot from them too. But just the conversation, they're so connected. And even my men, I was like, oh, I'm always worried that my men are gonna drop out because there's just not that conversation. I'm worried it's gonna be different for them. But I've had them come in and be like, look, my daughter thought that I wasn't gonna last this long, but I love these people and I love coming each week. So I'm like, good, tell your daughter that you're doing great. It's been such a good experience for us that I would say try it out if you're nervous about it, because they do amazing and they kind of push each other, I think, a little bit more than our regular groups do in the program, and they're so supportive of each other as well. So our next steps, we're gonna try to get more support from our physicians to get referrals coming in directly for the program, not for just the nutrition counseling that we're kind of getting now. We're doing that with lunch and learn meetings, meeting with a lot of the physicians' nurses and the physicians if they can come. My supervisor did a grand rounds presentation, which is a session a lot of physicians come to each week to learn about some health topics, so she got in and was able to present to them there. We're going to keep looking to expand MDPP beyond our one group, which I'm sure we'll be able to do, and then also expanding with our community groups as hopefully coverage continues to increase. Okay, sorry I didn't leave a lot of time for questions, but any questions that you have, here are some of my references. Yes.
I had a quick question about your the added sessions that you had. How were those cost effective with your program? I'd like to Heidi sponsor that, or how were you able to make that work? Those are pretty expensive.
We don't pay for the Hy-Vee. Like, we're not paying for that. The people, and that's another reason it's an optional thing, but almost all of my people come. It usually costs between like $60 to $100 because they're taking home all those groceries and they pay that themselves. What?
Your participants?
Yes, the participants each pay for that on their own. Yep.
what's your dropout rate so far? Because that's, I mean, when we do a
Struggle.
4-week diabetes class, we can't get people to come back.
Yeah.
We've all been there, so
Yep.
2 years makes me nervous.
With the Medicare,
Or even your 1-year program, what's your
Right.
dropout rate?
I always lose people. I always count on losing at least 2 people each group. But it's not as big of a deal with adding in those extra sessions. I thought it would be backwards if we were like bugging people to keep coming with those every other week sessions, that they wouldn't want to keep coming, but because of the support with the group, they keep coming if you keep at it. I don't know exactly what our dropout rate is. And even with the CDC reports, it's very hard to read because it's like by month, how many participants are in month 11 and how many, so it looks, I think, a lot higher than it actually is. I'm sorry, I can't answer that question very well. I always count on at least 2, and some groups, like the reason I don't like to start with less than 8, one of my 8-person groups is down to, I guess they're just down to 5, but still, it's like sometimes I only have 2 or 3 who show up at a session, and that's just not a good conversation. But yeah.
What is the cost if they don't do Medicare and if, like, let's say their insurance doesn't reimburse very good or?
Yep, so we went with, there were a lot of studies on like what's the least you can do, and I think it was like $465. We bill $500 per participant, just an even. And we bill it $100 over the first 5 weeks that they come. So that's how it works. And then our people who do have coverage, they still are paying 20% copay, so they're still paying $100. Yeah. Any other questions? Yeah.
Can they, if they get behind, can they jump back to a different group or do they have to stay with that?
I have them stay in their group. I have had a couple of circumstances where people are like, look, this is just an awful time in my life. Can I start over? Or not start over, but kind of jump in where I was. And we've let a couple people do that with a new group, but they're no longer participating in their old group at all. And I always make them come to the first session because I want, when we introduce ourselves and do the icebreakers, I want them to feel a part of the group rather than jumping in at week 6 or whatever. So yeah, they have to stick with their same people.
I think with Medicare, that's required.
That they have to
They
stay.
have to enact, and once they start, if they drop out, they can.
I think they can transfer to a different program though, because there is a charge that you can submit if somebody new comes in, but I don't know how it works within, yeah.
Do you use the curriculum? I'm assuming you're using the Prevent T2 curriculum.
We're using the Prevent T2
Do you
curriculum.
add stuff to that, or did you use it as written?
I do it as written, but I add lots of stuff to it. Yep, like the quotes on the wall, or we do a lot of stuff with resistance bands, or if you need a good website for activityfitnessblender.com is a lot of free videos, so we add a lot of stuff to the program. Yep. Did you have a question, or did anybody else have a question? Okay.
Quick question, that's 2-parter. First, do you keep track of where you get your referrals from?
All of our referrals are coming from our physicians if they're
Or like from
coming.
your community meetings or,
Oh.
you keep track of where people are having that?
I think I do mentally. I haven't written it down, but I always run to my boss's office. I'm like, hey, so-and-so called from the city of Ames, So that, but no, I'm not.
Do you think there's one strategy that's been really successful and any others?
That primetime conversation brought in a lot of people, and then that magazine article brought in, that's probably where we've gotten the most outside of our general population.
We have gotten, I'm one of the supervisors, and we have recently gotten some from our lunch and learns that we've done.
Okay.
We did some of those right before Liz was off, and we've actually got 3 or 4 referrals recently from that. So I think it's just kind of getting the word out and getting providers to understand the program, because they don't really get it necessarily, so.
Yeah, we're having some difficulty with provider engagement.
Yeah, it's like, well, why wouldn't you say that?
I think if you can brag on the national statistics and your own data statistics, and then also emphasize that support piece, those are our biggest selling points, is kind of the research, and then our own experience, so. Anything else? Yeah.
What time of day are you offering your classes?
Almost all times. I have a 7 a.m. to 8 a.m. group. We have some 3:30 to 4:30 groups, some 5 to 6. I haven't done any late evenings. I haven't had any interest in that. We've done a lot of lunch groups. Although I thought that was a great time at first, and now I tend to have people say, oh, I can't get away from work to take my lunch off. So I think I like the morning and the right after work times right now.
Is that something you discussed at the class 0 then, or?
Yep, so everybody who comes to session 0, I have them fill out a form including like what time is gonna work best for you, and then I pick the time that works best for most people in that group. And then the other ones, a lot of times will just say, yeah, I can make that work. It wasn't my favorite, but they'll come. So, yeah. Anything else? All right, well, thank you guys, and sorry I took more than an hour, but I love the program.